Hello everyone, this is section 2, intraoperative care. I've got you some pictures here just so that you can see what this OR suite as well as kind of like what an anesthesia machine looks like that is used in a case. These are the members of the surgical team. Make sure that you're aware we're going to do in class like an exercise where some groups are going to really look up and review what the roles and responsibilities of these are, but you need to know these all yourself as well. So when those are posted, make sure that you use those as a way to study and know what the difference between these roles are within a case. And of course this information is in your book as well. Minimally invasive and robotic surgery is now really a common practice. It's kind of preferred technique for many of the types of surgeries you see listed here. A laparoscope is used to enter the abdomen or in some cases other areas, chest cavities or even in joints and things, but is generally in a cavity. And in this case you can see they're using gas to kind of blow up the abdominal cavity, and that makes it easier for them to see different structures and organs in there. And then through the scopes themselves, they're able to do procedures with little tiny mechanisms that are inserted through the scopes to remove tissue, cauterize vessels, and do things like that and complete the case. This is an abdomen of somebody that's had an actual laparoscopic procedure. You notice that there's like 4 spots here where they have went in, and usually the umbilicus will be one of those. These are just a little pink, but they're not real bad. They're closed with a substance called Dermabond, which is an adhesive, skin adhesive that works really well without having to do a lot of sutures. Some of the complications that people can have from minimally invasive surgery is mechanical trauma, just from the instruments, being inside the cavity. They may hit other tissues or damage other places versus the areas that they expect to be working with. And then sometimes there can be thermal kind of burn injuries from the equipment as well. The environment of the operating room takes a lot of work. Not only is it a sterile area that has to be cleaned and sterilized repeatedly, and all of the equipment and things either used disposable or sterilized thoroughly, but the layout has to be set up. All the instruments are very unique and equipment is very unique to specific cases. So the team has got to really be in there and develop the whole setup of everything and how it's supposed to be and keep it all sterile throughout all that before they ever get started. And then people are such a source of bacteria that, there is heightened surveillance, watching for nosocomial infections or infections that come about because you were in a healthcare facility. And then they are constantly doing cultures of equipment, of people's hands, of surfaces, different equipment, all that to kind of constantly watch to see if they're doing an excellent job of sterilizing things after the fact. And then identifying, is there a source of some type of infection that they can find. This is just an example of surgical scrubbing. They're using surgical antimicrobial solution, vigorous rubbing with a lot of friction from the fingertips all the way down to the elbows. They scrub for 3 to 5 minutes. Here's kind of the real life scenario of what it looks like. And then of course they don their gowns and gloves with assistance usually from someone else, so that they are very careful not to contaminate themselves in any kind of way. We're going to talk about anesthesia. It is an induced state or partial or total loss of sensation that occurs with or without loss of consciousness. So it just depends on how deep the anesthesia is. It can be used to block nerve impulse transmission, suppress reflexes, promote muscle relaxation, and achieve a controlled level of unconsciousness in some cases as is needed depending on the significance of the surgery. General anesthesia is what we think about with kind of major surgical cases. But this is a reversible loss of consciousness that's induced by inhibiting neuronal impulses on several areas of the central nervous system. It can involve a single agent, anesthetic agent, or combination. It depresses the central nervous system. It results in, pain control, sometimes amnesia, where the patient has no memory of the surgery, and then they'll be unconscious with loss of muscle tone and reflexes, meaning that their muscles don't react to anything that is occurring to their body. It is usually administered through an inhalation and IV injection. It's two different methods, or what you see, or what commonly is done is balanced anesthesia, where there's a mixture of inhalation and a mixture along with giving IVs at the same time. These are the 4 stages of general anesthesia. You can kind of see you start out with just kind of a pain control and sedation and relaxation. Stage 2, the person gets much more kind of out of it and in a delirium state. Stage 3 is really when they get down to true operative anesthesia. Stage 4 is too much sedation and is considered a danger level. And then you'll hear the term emergence, meaning that they're beginning to emerge out of anesthesia when the anesthesia begins to wear off. Again, this is an example of balanced anesthesia, where 4 different drugs are being given for all different reasons. And I would encourage you to look at these drug classes. Of course you will for morphine because of pain management, but know these other things like thiopental, nitrous oxide, pancuronium, and look at what drugs are in those categories that are used for those different purposes. Complications that can occur from general anesthesia. Obviously people can overdose, and you can be more in a stage 4 situation where it's very difficult. Sometimes patients can be under general anesthesia and maybe their respiratory status is not being monitored like it should be, and they might not be breathing very much, what you call hypoventilation. They could also have intubation problems where their tube was dislodged or not in the right place, and so their breathing and their oxygenation is very problematic. And then sometimes people just have problems with specific anesthetic agents that you weren't able to know about in advance. One of the serious life-threatening concerns that you can have from anesthesia is a condition called malignant hyperthermia. And this complication can be genetic. It begins with skeletal muscle being exposed to the specific anesthetic agent, and it causes increased metabolism. Calcium levels in the muscle cells rise, and it causes acidosis, and very high temperatures and dysrhythmia, and can lead to death. So recognizing these clinical manifestations early is really important. If the patient becomes very tachycardic, that's not normal. If they start having skin mottling, meaning like kind of light blotchy places in different areas on the skin, or cyanosis. And of course, temperature monitoring is very important. Some of these other things you might do to double check after the fact. Now we're going to talk about local anesthesia. Many of you have had this. If you've been to the dentist and had, some numbing medication before you had dental work, you had local anesthesia. It can be delivered topically, just meaning on the skin, just to numb the surface of the skin, or it can be actually injected like it is at the dentist office, with a local infiltration to kind of numb a specific area. The patient, of course, remains conscious and able to follow instructions. And this is another type of anesthesia, which is regional anesthesia, where we kind of began to talk a little bit about in pain class the other day, where nerves are blocked by an agent with injections kind of right where it into the nerve area, and then it kind of makes the rest of the conduction of that feeling below that not possible. You can have field anesthesia where it is covering multiple, a field of several different nerves, or you can have individual nerve anesthesia, or you can have spinal or epidural like we talked about. These are just some pictures of spinal and epidural. You can kind of see where the needles are being inserted in the subarachnoid space, and where they're being done with the epidural is kind of between L2, 3, 4 in that area. On the top you see the lady laying on her back curled up in a ball, and that's a pretty common space laying position for this to be done. But on the right you see someone sitting up on the side of the bed. Of course it is done as a sterile procedure just like you see, but sometimes they sit on the side of the bed and kind of lean over the bedside table, and that's as easy to do as laying on their side. These are some of the complications that you can see of local or regional anesthesia. Some people can have anaphylaxis, which means like a severe allergic reaction to medication, which can stop them from breathing, having hives, different kinds of things that you would see with that. Sometimes they can get the medicine given in an incorrect delivery technique, and they miss the area, and so the numbing has not occurred properly. Sometimes they can get too much of it, and it can absorb not just in that space, but kind of get into the central nervous system and cause some problems. They can overdose on the medication. It can get too high up the spinal column to the point where it causes them to not be able to breathe properly. And then sometimes you can just have local complications in an area where something was administered and it didn't, the skin or the tissues damaged. Treatment of complications, because you want to be concerned about anaphylaxis shock, is opening the airway, giving oxygen, notify the surgeon, and then usually they're going to order different kinds of meds to specifically treat the condition itself and the symptoms. Moderate sedation is a type of sedation that's given with IV delivery of sedatives, hypnotics, opioid drugs to kind of reduce the level of consciousness. The patient really maintains their own patent airway and can respond to verbal commands, and the amnesia action is somewhat short. So that is a little different than general sedation, because it's more like for a short-term procedure or something where you just have to give them a little bit and do something really quick, and then you're done with the procedure. Collaborative management, I'll just kind of briefly say that some of the same reviews that needed to be done preoperatively in terms of medical record, allergies, knowing about reactions to transfusions and other things, all this information needs to be conveyed throughout related to any issues that occurred in the OR situation. These are some pictures of some common surgical positions, just to know that cases are done in different ways to get at specific organs. Potentials for injury occur because of this, because patients are laying in one position sometimes for hours. So they may have pressure ulcers actually form because they're not able to tell you that something is pressing or hurting, or that blood flow is being cut off in their extremity, or nerves being damaged by the way they're laying. Of course, there's potential for infection. They sometimes have dressings, drains, sutures, lots of things that require special precautions, and we'll talk more about that in our next class. These are some common skin closures that you may see. Just know kind of the differences. And these are some of the things that you really want to look for with hypoventilation, continuous monitoring for their breathing, circulation, cardiac rhythms, blood pressure and heart rate, and then continuous presence of an anesthesia provider being present at all times during the case in the operating room. They are not allowed to leave until that patient is really moved on to the PACU. So that's important to know, that not just the nurses are monitoring that, but you actually have continuous presence of the anesthesia provider there at all times. This ends section 2.